So, once again, good morning to everyone. So, we have a case number 38, 2020, a 52-year-old man with cancer and acute hypoxemia. So, I, Harris Khordkabuli, Geoff Kurikesu, and Humza Khan will be presenting today for you. So, a 52-year-old man was admitted to a hospital for suspected cancer, and then after 5 days, uh, he was evaluated for hypoxemia. So we have a medical history for the patient: hypertension. He had hypertension, dyslipidemia, obesity, and hyperthyroidism. He had allergies to peanuts and latex cause of urticaria. Uh, Family and social history. He has in his family there was multiple relatives which had hypertension and diabetes mellitus. For his social life, he was working as a security, and he is not using any alcohol, tobacco, or any other illicit substances. He was identifying himself as black and as his race. Jehovah's Witness. He is he was denying receiving blood transfusion um, because of his own beliefs. He had a onset uh, on presentation to hospital. Patient developed severe, sharp, and burning pain in the right shoulder, on triceps, and upper and middle back. And in addition to that, he had a fatigue and increased urinary frequency. On his physical exam, in on vitals, his temperature was 37.1 Celsius, and heart rate was 95 beats per minute, and blood pressure was 162/88, and the respiratory rate was 19 breaths per minute. Oxygen saturation was 99% on ambient air, and on musculoskeletal uh, examinations, um, there was a paraspinal muscle tender, and it was more on the right side than the left. Strength was 4 out of 5 when the patient extended his right shoulder and when he gripped the examiner's fingers with his right hand. Straight leg rising was normal on both legs lateral, and on labs and imaging, on MRI and CT, there was a mass in the right posterior aspect of T1 vertebrae with subsequent stenosis. Like if you can see on A, there's a mass here. So, uh, and there was also shown a compression deformity of many vertebral bodies, including T9. In you can see it on picture B. We have like this compression. There was a compression on the vertebrae, and a CT confirmed lytic lesions at T1 and compression of many thoracic vertebral bodies. We can also see it on D. There is a compressions. On labs and investigations, so we have there was no any specific uh, there was no significant any changes. There was only we can see hypercalcemia, high level of calcium uh, because of maybe because of cancer, and increased uric acid because of administration of resveratrol. Um, Here we see uric acids. So and handing over to Jeff.
Okay, so his clinical course, obviously he came in for some pain in his musculoskeletal pain. So the initial suspicion was for some cancer diagnosis. So they admitted him, and on the second day, he appeared lethargic. He had a flat affect. He had continued decreased sensation on fingers. Drug regimen given on that day was he was given oral acetaminophen, calcitonin, intravenous lactated ringer solution, hydromorphone for pain, diazepam, and then the zoledronic acid. The zoledronic acid is pretty much given for hypercalcemia. Um, the hypercalcemia is, like Harris said, suspicion from cancer. Okay, next slide, please. Day three. So his conditions slowly started to deteriorate. He had on lung auscultation, he had bivascular crackles. He was given supplemental O2 through the nose. He was started on lactated ringers and lactated ringers and zoledronic acid were stopped. He was given IV saline, furosemide, and dexamethasone. Next slide, please. Day four, a CT bone marrow was performed. They found trace edema in his leg, barrel-shaped crystals in the urine sediment, along with 5 grams of protein in the urine sample was also found. So this day is kind of where his symptoms really uh, kind of downfalled. And it's mostly because due to he was given cold calciferol and IV respiracase because of the increased uric acid in uric acid crystals in his urine. His stool was also guaiac negative. Day five. Next slide, please. Okay, so this is kind of like pretty much where the case really starts. His O2 saturation decreased from to 86% without shortness of breath. His rate of O2 administration was also increased, but it was kind of funny because the O2 saturation did not increase along with it. Temperature kind of stayed the same. He came in super hypertensive. I think it was around like 160 over something, but that pretty much dropped to normal once he started on this respiracase. So there was kind of indications of, okay, this guy is kind of hypoxemic. So what is kind of causing this issue? So chest imaging was done, and it showed clear lung volumes, low lung volumes, and clear lungs. He was started on high flow oxygen therapy, but O2 saturation remained unchanged. It wasn't improving. So the red flag that really started kind of like the deterioration of all the symptoms was a decreased O2 saturation with initial pulse oximetry. Next slide, please. So the physicians, obviously on this team, they were kind of uh, they cancer suspicion was one of the obvious diagnoses, but for his current acute symptoms and what was going on currently, it was something had to do with the hypoxemia. So some differentials that they came up with were pulmonary embolism, hypoventilation, shunting, and methylglobinemia due to G6PD deficiency. So I'm just going to run through these differentials and why it and kind of rule out ones that were not possible. So pulmonary embolism. He did have some risk factors for this. He did have some fractures, suspected cancer, and he was also an inpatient. Um, and then also he did have anemia, and his religious beliefs, not having blood transfusion, are major risks for initiating anticoagulation therapy. He also did have some nephropathy, which is also contribute to risk factors for PE. The reason why, so this differential was kind of just kept in the back of the minds of the physician team because there is risk for further workup and treatment for this issue. It can kind of deteriorate the patient's symptoms even more. So they kind of wanted to pursue further differentials while also keeping this in the back of their mind. So hypoventilation, I'm going to touch on this if and also a saturation gap and that relationship to hypoxemia. So hypoventilation related hypoxemia. In this patient, there was no lower respiratory rate or tidal volume, and then there was also an abnormal alveolar arterial gradient. So that kind of ruled out hypoxemia related to hypoventilation. Um, there was also an O2 saturation gap present. This is pretty much a difference in O2 saturation measured in pulse ox versus blood gas analysis. And it was found that the pulse ox O2 saturation was 86% and blood gas analysis O2 saturation was 99.2%. So a hypoxemia related to an O2 saturation gap was the main indicator and kind of the main way that they needed to focus these differentials from this point onwards. Okay, so shunting could lead to hypoxemia with O2 saturation gap. In right to left shunt, hypoxemia can occur due to blood not participating in gas exchange before entering the systemic circulation. This could be due to a lung collapse, atelectasis, or process that leads to alveolar filling that can cause shunting, but no alveolar filling. Intrapulmonary shunt in context of clear lungs, as stated when they did radiography, there was low lung volumes and clear lungs, is limited to conditions associated with AV connection issues. Due to hepatopulmonary syndrome or anatomical anomalies, but clearly in this patient, there were no indications of any of that. An acute right to left shunt can also occur in adults with structural heart disease. This is due to undiscovered issues like patent foramen ovale or due to PE. Obviously, he didn't have patent foramen ovale. PE was still a suspicious diagnosis, so this was still kind of considered. Right to left shunt can also cause hypoxemia due to interatrial location, but in this case, this would not cause the specific O2 saturation gap that was found. Next slide. Okay, so they kind of pretty much narrowed it to dyshemoglobinemia. Dyshemoglobinemia is pretty much there's three variants of hemoglobin, and methemoglobinemia is the one that can lead to skewed O2 saturation levels and lead to a saturation gap. Patients with G6PD deficiency are at an elevated risk of methemoglobinemia induced by respiratory. Respiratory, keep in mind, was given because of the increased uric acid levels. So that was given to kind of reduce that. So you need to measure the G6PD levels before you administer respiratory. The reason why it was the G6PD wasn't really caught, I guess, initially was because it is obviously common in African Americans, but it's hard to notice a cyanosis due to the darker skin. The patient was also given methylene blue, which kind of worsened his symptoms, kind of starting on day 4, borderline day 5. I don't think I mentioned that, but he was given methylene blue due to suspicion of this, and that kind of caused even worse his symptoms to deteriorate, and it also caused hemolysis. I think that's it, and I think Hamza will take over from here.
Okay, so after discussion of the differential diagnoses, the physicians came to the conclusion that the patient has a G6PD deficiency along with methylglobinemia. And so uh, G6PD, as we all know, is an enzyme that is responsible for antioxidant functions. And what happens is that G6PD is converted from glucose and generates NADPH from NAD, and then the NADPH is then further converted into glutathione, and glutathione is responsible for directly inactivating oxidant molecules such as hydrogen peroxide, sorry. And then NADPH is also included in various NADPH methemoglobin reductase activity. And as mentioned before by Geoff, methylene blue is also a treatment option, but in this case, with G6PD, it can actually worsen the symptoms of hemolysis and methemoglobinemia. And a main characteristic feature of G6PD deficiency is the bite cells that are seen on the peripheral blood smear. And what a bite cell is the oxidized hemoglobin. It precipitates within these blood cells, and a portion of the blood cell is bitten off essentially or removed by the spleen, and this eventually will cause the clearance of the entire red blood cell. And so the oxidative stress that results from the hydrogen peroxide that is generated, it can increase iron and protein oxidation, which then in turn causes methemoglobinemia and hemolysis in the patient. And as Geoff also said before, there's a high prevalence in black men. And what rasburicase itself does is that it converts uric acid into allantoin and high amounts of hydrogen peroxide, which, as I mentioned before, causes the oxidative stress on the red blood cells and can lead to the hemolytic anemia as well as methemoglobinemia. And specifically, I'm sorry, can you go back for a second? So as we know, glucose 6 phosphate, it also when after being converted into glutathione via glutathione reductase, it is then it converts hydrogen peroxide into water with glutathione peroxidase, and this will reduce the oxidative stress that is caused from the hydrogen peroxide. Next slide, please. All right, so methemoglobinemia is methemoglobin is a form of heme iron that is oxidized from the ferrous state to the ferric state, leaving it unable to bind to oxygen molecules, and this will cause the hypoxemia as we saw in the patient, because the hemoglobin that's left over that is unable to bind, it will bind the oxygen more tightly, and shifting this, as we remember, the oxygen hemoglobin dissociation curve left, which will in turn decrease the amount of oxygen that the tissues receive, which is why the patient was hypoxic. And in this patient, we saw that the concentration of methemoglobin in the patient was 7.4, which is extremely high because the normal range, as we see, is 0.0 to 1.5. And this diagram, the first picture, it shows the how oxidative stress on hemoglobin is like the process of it. And when the hemoglobin tetramer is exposed to this stress, it becomes oxidized, and the ferrous ion Fe2 plus is oxidized to the ferric ion Fe3 plus. And so the NADH methemoglobin reductase and NADPH, they reduce this back to the Fe2 plus, and glutathione further oxidizes the hemoglobin to its native form. And so the bottom panel will show the G6PD effect on this process. And so G6PD will transfer 2 electrons and 1 hydrogen from G6 glucose 6 phosphate to NADP, and this will produce NADPH and a free proton, and this will donate to another electron, reducing the oxidative stress on these proteins, on these red blood cells. Sorry. Next slide, please. I also wanted to mention that this oxidative stress can cause kidney injury, and as we saw in the patient, there was hypercalcemia. But there's also the excess free hemoglobin will exceed the binding capacity of haptoglobin, which will lead to hemoglobin dimers small enough that are filtered through the glomerulus and cause injury to the kidneys. And there's also obstruction of obstruction in the renal tract by hemoglobin and cytotoxicity of hemoglobin of the proximal tubule. All right, so this patient specifically did not initially present with any anemia, or not anemia, with hypoxemia, and rather he developed this hypoxemia after day 3 when he was given the IV rasburicase. And the patient initially presented with the back pain, that is due to what was found later in his bone marrow biopsy of the IgA lambda chain multiple myeloma. And as you can see, his symptoms perfectly align with this diagnosis, as he presented with back pain. He had anemia, hypercalcemia, injury to his kidneys. He had lesions in his T1, T9 vertebra, and the hypercalcemia was due to the osteolysis because of uh, the bone reabsorption. And this this basically is the cause of why his G6PD deficiency occurred, because this patient was given the IV rasburicase, and that paired with the multiple myeloma sent him down the hemolytic anemia and methemoglobinemia uh, pathology. And multiple myeloma is a cancer of the plasma cells also. The plasma cells are a type of white blood cell in the bone marrow. Um, the plasma cells are, as you can see in the picture, they're cancerous and multiply, and this these cells can spread to the bones, immune system, kidneys, and affect the red blood cell count. Okay.
Oh, please go
So
on.
this patient, I'm sorry.
I'm just saying, please go on. Great.
Okay. So this patient was uh, obviously this patient is a Jehovah's Witness. So the normal treatment would be to give him a transfusion of the precipitating agent and red blood cells. However, because he is a Jehovah's Witness and will not accept the transfusion, he can receive an erythropoietin stimulating agent as well as IV iron. But as we said before, methylene blue wouldn't be effective in treating because of the G6PD deficiency. However, if given with vitamin C, there is some it is seemed to have some effectiveness, but it's not quite effective still. Next slide, please. So for this patient, we did not obviously do a transfusion, but to treat the anemia, we gave him erythropoietin, intravenous iron, and vitamin C. And to treat the cancer, multiple myeloma, he received radiation therapy as well as chemo with lenalidomide, bortezomib, and dexamethasone. Next slide, please. So initially, the hypercalcemia and hemolysis resolved following the administration of those uh, medications, and the renal function then in turn normalized. Next slide, please. Okay, following 9 months of treatment, and after all treatment is successfully finished, he received a bloodless autologous stem cell transplantation and continued the maintenance therapy. And after assessing the bone marrow once again after 9 months, it is found that the patient has been cleared of all residual disease and is healthy.
So, for the summary of case, we have a 52-year-old man presented to the hospital following back pain, and on the fourth day of following admission, he developed hypoxemia. As a result of being administered, rasburicin was administered in the hospital. The patient was treated for suspected cancer, as a lytic lesion was found on radiography images. Um, the patient was diagnosed with methemoglobinemia with G6PD deficiency on the fourth day in the hospital. He was also found to have IgA lambda multiple myeloma. He was treated subsequently for anemia as well as for cancer therapy. He was also administered. The patient recovered successfully following treatment and no further disease residual found. So we have a citation. Any questions?
Wonderful, wonderful. Thank you. I have a few questions submitted by various groups. So, group 2, please name other causes of G6PD deficiency.
Okay, so it's a hereditary condition, so it's passed down. Um,
So it's